This is Jody Tropiano, the Content Director for Health, and I'm here with Dr. Farzad Mostashari, the CEO and co-founder of Aledade. Farzad, thanks for joining us.
Thanks for having me.
So we're excited to get some of your insights into the COVID-19 pandemic. I know from following your Twitter, you have tons to say, so we really are looking forward to this conversation.
Absolutely.
So first off, would just love to know what Aledade has been up to in regards to your response to the pandemic.
Yeah, this was one where, having had training as a medical epidemiologist and a former epidemic intelligence service officer at the CDC, turned in handy for us because very early on, I'd been tracking this and looking at the exponential thread and kind of alerted the company that we needed to get ready at a time when there were very, very few cases in the US. And we launched kind of a whole company effort soon thereafter. And by March 12th, we were in full swing. And we focused on four primary areas. One, telemedicine, to help our practices be able to continue seeing patients. And we went from 100 to 10,000 televisits in 2 weeks with our practices. We stood up 150 practices over a weekend so that on Monday they could begin to safely see their patients at home. The second issue we focused on really quickly was the need for PPE for our practices. I was looking at the data and seeing that there were a lot of patients coming into those practices with flu-like, or we now know COVID-like symptoms, and the need for them to be able to protect themselves and their other patients from getting sick. So we scrambled, and these practices don't have access. The supply chain is completely broken, as you now know, for masks and gloves and gowns. And so we aggregated these 500 practices, went out to a major distributor and got 386,000 masks ordered and now delivered to the practices. The third thing we focused on was communicating with our patients. So over 100,000 letters, postcards, phone calls, messages to tell them, give them guidance on how to keep themselves safe. And then finally, and this is sad, but our business is value-based care. It's not fee-for-service, but our practices still have a significant number of fee-for-service revenue that they're dependent on to keep their offices open. And they, like every other primary care practice in America, is in real financial straits. And so we've been helping them navigate the various loans and grants and other options for them to stay in business at a time when the country needs them.
Yep, that's great. And so on top of that, you also co-authored a plan about a national surveillance system to reopen the economy. So since you've offered that, what part of the plan do you think we're at right now, and what do we need to move forward into the next phase?
Yeah, it's not great, I guess I would say, that we have improved on testing. One of our first recommendations was being able to track the percent of tests that are positive to account for changes in testing variability. That I think we've made good progress on. But fundamentally, what we need to do to safely reopen is we need to diagnose a very high percent of symptomatic cases have to be diagnosed. In the initial phase of this thing, we were telling people, if you're sick, stay home, right? Stay home. You don't need to come in and get tested. If we want to have any hope of reclaiming containment, then as the number of cases go down, we have to be doing more and more contact tracing, case investigations, and getting people tested. So now the advice is going to have to flip. People need to actually, if they have symptoms, they need to get tested so they can be diagnosed quickly and that their contacts can be diagnosed and isolated. So there's a major push. I was part of a bipartisan letter asking Congress for funding for state and local health departments to do contact tracing, income replacement, hoteling, and so forth. But that has to be accompanied by a real reliance on frontline primary care practices to be able to do testing at scale. Mm-hmm. And that is a key area of weakness right now for the US.
And with contact tracing, digging a little deeper, so getting primary care involved, you just mentioned, is one solution. But what about patient data? Do we need to ease some of the sharing standards, interoperability, which I know you speak a lot about? How does that play a role in contact tracing?
There isn't really a need to change HIPAA or anything else like that. There are already provisions for public health investigations there. Where I think that there are more concerns is around these ideas of these, Bluetooth apps that'll track every contact everyone made with everybody else, and somehow magically, everyone will be notified and there'd be no threats to privacy. I think that's kind of naive on both ends, both on the public health utility of these, which make like several leaps of faith and assumptions from a public health point of view, and then also from the privacy point of view.
So do you think that contact tracing will come from the government and not some of the private sector initiatives that are out there?
I think that it sounds a lot different when you say it'll come from the government versus it'll come from your state and local public health department, who already does contact tracing for people with tuberculosis and measles, right? Those same people who do contact tracing for measles should be doing the contact tracing for COVID. I don't think we want a centralized either government, government writ large, nor centralized big tech surveillance in our lives.
Mm-hmm. Makes a lot of sense. And so going back to primary care, what role can primary care physicians really play in the solution for this, since they are really front lines for contact tracing and for just caring for patients with chronic conditions?
Yeah, the first really important role is to diagnose the cases, and our practices are really on the front lines of that. They're doing it now with inadequate PPE. They're doing it in parking lots. They're doing it on porches. But we need to really arm and fund independent primary care practices to be able to do massive testing for people and identify those who are positive. We don't want everyone to flood into the emergency rooms to get tested. The second thing that they have to do is they have to continue to care for people who have untreated chronic diseases. So that heart disease didn't go away. That kidney failure didn't go away. Those people with community-acquired pneumonia still have community-acquired pneumonia. So we can risk a much increased rate of deaths from untreated chronic conditions unless we continue to provide access to primary care. And so that's the second thing that they have to do, is they have to continue to deliver effective primary care despite the challenges that we have. And third is that they need to, I think, be engaged in more with public health. So if public health identifies a patient who's a contact who needs to stay in isolation and be checked on for 14 days, one of the questions that came up in New York City was, well, what if we have housed someone in a hotel and they start to feel sick? What do we do then? Like, our public health people aren't medical doctors. How would they advise them on whether they should go into the emergency room or stay in the hotel? So there need to be episodes, essentially, of primary care, 14-day episodes where primary care would be involved in and paid for, providing that sort of ongoing monitoring. That was one of our recommendations with Mark McClellan, former FDA and CMS administrator, and I and Tom Barker out of the Margolis Center made those series of recommendations around funding primary care to become more of a part of this whole COVID effort.
Mm-hmm. And about funding, I mean, we've been reading a lot about the financial strain that a lot of primary care practices are facing right now. So how could we better target our support for them as a health ecosystem?
We're just pumping out trillions of dollars in economic stimulus. Mm-hmm. And yet, there's money earmarked, tens of billions of dollars of money earmarked for various industries. And there's been $0 earmarked, dedicated to primary care. It just makes no sense to me. Absolutely no sense to me. And I think primary care, I will proudly say to all those who say, well, everyone's hurting. I would say, no, primary care is special, because primary care is who's going to get us out of this, right? Mm-hmm. Like, it's fine to say we need to support the restaurants, or we need to support ophthalmologists, or we need to support whatever. But unless you have functioning primary care, and many primary care practices with their thin margins, with a decline in revenue that they're getting from fee-for-service, are going to go out of business. And just imagine what we're doing, the double whammy of removing healthcare capacity at the exact same time that we need it to be there.
So maybe that's one example, but what other ways do you think the health ecosystem will fundamentally be reshaped because of this crisis?
Well, I hope that there will be some positive ways in which it's reshaped as well. Telemedicine is, I believe, here to stay. And I'm quite optimistic that both patients, providers, and payers will all see that, oh, this wasn't so bad. And a significant portion, maybe 40, 50% of all visits can be done through telemedicine in days to come. I also think that there's going to be more of an understanding that we can't rely on fee-for-service and face-to-face visits. Like, who thought that was the right idea anyway, to provide for funding? And I can see both payers and employers and primary care being more open to a monthly payment for taking care of a patient's primary care needs instead of being a face-to-face visit being the only way you can be paid. So I could see more of a shift to person-based rather than transactional, episode-based payment models. Of course, and that's great. And that's great for value-based care. But the countervailing force, the kryptonite for value-based care, is monopoly and consolidation. And I also see that threat, that a lot of practices are going to go out of business and they're going to be snatched up by those who are circling right now, hospitals, but also private equity firms, payers, and other aggregators.
And how have you had to work with some of your partners in new ways because of this crisis?
Well, we have had to serve them whatever, like our motto is service. So whatever they needed. We never thought that we would be in the telemedicine business. We never thought that we would be in the finding masks business. But those are the things that we've had to do to do whatever it takes to support our practices. And I think it's really helped the company get stronger. The level of commitment and mission and morale at the company has never been higher.
Mm-hmm. And you speak a lot about data. So how could we better leverage data now more than ever?
I think one of the things that was in the interoperability rule that CMS and ONC put out in response to the Cures Act, not the CARES Act, but the Cures Act, was requiring that hospitals share information with community physicians as a condition of participation in Medicare. And a reporter asked me, should we relax that given the outbreak? And I'm like, no, we should. This is exactly why. The times of crisis, Katrina was a moment where I remember people saying like, oh, we can't count on paper, right? When those waterlogged paper charts were destroyed and patients' medical history was irretrievable. We realized we need electronic health records. When Hurricane Sandy came, we were like, oh my gosh, we need to be able to share information that is now electronic. And I think we're now at this again, COVID makes clear that that information has to be shared, not just between healthcare entities, but also with public health.
Mm-hmm. And so what other misnomers do you think are out there right now? Any misconceptions? There's so many articles, so many webinars, so much information getting passed around. What do you think our audience needs to know that is not correct?
Well, I think there was a sense that the best we can hope for is to flatten the curve. Mm-hmm. That the best we can hope for is to have the same number of cases just spread out. And I think we've learned two things. The first is, if you let this thing rage, it's really bad. So New York City in the week April 4th to April 11th had more deaths than any other week in New York City's history, including 1918 pandemic flu. This is not the flu. This is, if we let this thing infect 60, 70% of the population, it is catastrophic. And I don't care if it happens all at once or you spread it out over a year and a half. We cannot afford to let 1.5 million, 2 million Americans die just by spreading this out. We have to, and I think this is the second bit of information, we have hope that the social distancing that we've all done has had a massive, dramatic effect of reducing the reproductive number of this thing to being at or almost around 1 from 2.5 to, or even higher. So I think there's also hope that if we can get our act together and if we can leverage the technology that we have, the incredible workforce that we have, the healthcare workers in the field, that we can actually reclaim containment and raise our hopes a bit, that it's not just flattening the curve and spreading it out over in time, a longer time period, but that we can actually avoid having 1.5 million deaths over the next 18 months in America. That to me is what we should be working towards.
That's good advice. And so do you think we should also be preparing for a second wave? Is that inevitable at this point?
I think that it's very, nothing is predictable about this outbreak, but I think my expectation would be that this continues to smolder over the next few months, where we are going to continue to have 30 or 40,000 recognized cases a day. And that means that we probably are going to have a couple of 100,000 total cases, infections every day in America for the next many, many, many months. And assuming a 1% or 0.5% infection fatality rate, that means, 9/11 every day. 9/11 every day, until we find either containment, reclaim containment, or we find effective treatments and vaccines.
And with the treatment and vaccines, when do you think is a realistic timeline there? I know a lot is unknown.
Yeah, I'm more optimistic in terms of treatment, at least partially effective treatment being available sooner than vaccine. I think vaccine, everyone seems to be saying the best case is 12 to 18 months.
Okay. So any last thoughts or just future projections of what we're looking like 6 months, a year from now? What does the other side of this crisis look like for us?
I think we're going to learn a lot about who we are as individuals, as communities, as companies, and as a country. And what I've seen so far actually gives me incredible hope that we're going to see acts of innovation, of ingenuity, of sacrifice that are going to help us define ourselves and for the rest of this generation.
Excellent. Well, thank you so much, Farzad, for sharing this with us. We look forward to catching up with you again soon, and best of luck on the front lines. Appreciate all that you're doing.
Thank you. It's really a pleasure to serve the primary care docs that we do, 550 of them in 27 states doing God's work. Thank you.
Thank you. Thanks for watching this interview. We're doing our best to keep our health community up to date and informed as the pandemic progresses. So please check back for more interviews and blog pieces with leading health experts, as well as check out our Health COVID resource page for more information. Thanks again.